Hello everyone, my name is Gyula Szőcs. I would like to share my 3 months progress report with you. My topic is investigating the safety and efficacy of surgical and conservative knee cartilage preserving techniques. A little bit about myself. I work at the Uzsoki Hospital as a resident at the Department of Orthopedics and Traumatology. My supervisor is Gyula Hangodi. Our vision is to decrease the number of total knee arthroplasties in Hungary, and we would like to achieve that by increasing the use of knee cartilage preserving practices. Okay, so we have 2 ongoing projects right now regarding cartilage preserving practices. Our first project started September of this year. It's comparing the safety and efficacy of meniscal repair and meniscectomy during anterior cruciate ligament reconstruction. It's going to be a meta-analysis. A little bit about the background you already heard from Mickey and Robbie. So the anterior cruciate ligament connects the femur to the tibia, and it has the main role of stabilizing the knee joint. It gives also rotational stability to the joint. There are approximately 200,000 ACL ruptures per year in the United States, and from these ruptures, more than 50% are reconstructed. During an ACL injury, then there can be other structures that are getting injured. So around 55% of the cases there is a lateral meniscal tear, and around 45% of the cases there is a medial meniscal tear. So menisci of the knee joint are a C-shaped fibrocartilage that increase stability and distribute load inside the knee joint. There are 2 major operative treatments for torn meniscus. One is meniscectomy, which is basically removal of the damaged part, but it can lead to instability. The other surgical option is meniscus repair, which is suturing or reattaching the torn meniscus, and this way we can keep the stability of the knee joint. It has been shown that repairing the meniscus can prevent early onset osteoarthritis, but still, in 94% of the cases, there is a meniscectomy performed, and only around 6% of the cases there is meniscal repair. So our aim is to compare the safety and effectiveness of meniscus repair and meniscectomy during primary ACL reconstruction. So our clinical question is, does meniscal repair have a better result than meniscectomy during ACL reconstruction? We are investigating patients with concomitant ACL and meniscus tears, and we would like to compare these 2 operative actions. We are looking for mainly clinical scores as outcomes, but we are also interested in failure rates and septic complications as well. Our hypothesis is that because of the stability of the knee joint, meniscus repair is superior to meniscectomy during ACL reconstruction. The clinical implication is that by increasing the stability and effectiveness in ACL reconstruction, we can postpone early onset osteoarthritis, and we can decrease the number of total knee arthroplasties. We conducted our systematic research at the end of October of this year in the 3 major databases. We got more than 10,000 articles, and now we've just finished the full text selection. Our second project started November of this year. It's investigating the safety and efficacy of intra-articular injections in the treatment of knee osteoarthritis. It's going to be a network meta-analysis. So about the background, osteoarthritis, as you may know, is a degenerative joint disease that results from breakdown of joint cartilage and the underlying bone. Most common symptoms are joint pain, swelling, and decreased range of motion. Osteoarthritis is affecting around 30 million people in the United States alone, and of these cases, almost 80% of them are related to the knee joint. There are 2 major treatment options for knee osteoarthritis. It can be either surgical, which is basically arthroplasty, and the other option is conservative therapy. One of the most widely used conservative therapies is intra-articular injections. They present a low risk of harm while providing short-term pain reduction and improved joint function. There are several types of this kind of injections, just to mention a few: corticosteroids, platelet-rich plasma, and hyaluronic acid. But the problem is with them that there is no clear recommendation today, and also recent studies shows great success if we combine hyaluronic acid with PRP. So our aim is to compare the effectiveness and safety of these different intra-articular injections. So this is basically our clinical question. We would obviously like to investigate patients with knee osteoarthritis and compare the different intra-articular options. We are looking for clinical outcomes as well as septic complications. Our hypothesis says that if we combine hyaluronic acid with PRP, it's going to be superior to any other intra-articular options. And our clinical implication is basically the same as before or at the first project. We would like to decrease the number of total knee arthroplasties. We are planning to do the systematic search this month. Okay, so this is our 2 ongoing projects right now regarding knee cartilage preserving techniques. We would like to finish both of them at the first half of next year. And I brought you a quote from Toy Story, to infinity and beyond. Thank you very much for your attention.
One question is just out of interest about your second project. In the background, you said there are lots of intra-articular injections which can help, and I can see Botox, botulinum toxin type A.
It's a newer one.
So how that works? I thought that in the there are no muscles within the in the joint.
I'm not sure how it works, to be honest. They started to investigate it in the last few years.
I thought we are injecting muscles to make them real. Anyway, okay, so it's a new one, but it's really intra-articular.
Yes.
Okay.
Yeah,
and
also
then
doing ozone.
And then
if you are wondering, if they are also doing ozone intra-articular injections lately, so.
Okay. And if we go to the search key of this project, so platelet-rich plasma PRP.
Yeah. So it's not finalized yet. We didn't do the prospect.
Yeah, and so but if you really want to do a network, you have to put everything in the search key. So I would have expected botulinum toxin here as well.
Yeah, it's missing from the search key.
And instead of corticosteroids, all of the corticosteroids which I used for it, but no, lots of hits so far.
Yeah, I know. So it's not finalized search key.
Yeah, if you go back to your first Prisma flow chart, first project's Prisma flow chart, yeah, I congratulate you on that. Yeah, that's big stuff. I mean, 0.8 Quantz kappa for 7,000 hits, and then 400 with Quantz kappa 1. Well done. Lots of studies.
Thank you for the nice presentation. My question is about your first project.
First project, okay.
Yes. What type of studies did you find? Are they cohorts? Are they RCTs? Because I'm wondering whether...
Unfortunately, I believe there are RCT, and all the others are, unfortunately, not prospective studies.
Yeah, I'm asking because I assume that one of the procedures is better for the more severe or less severe situations, and that's why I asked.
Yeah, I mean, I have the same problem as a few of my colleagues before with the population. So it's not necessarily the same indication for the two different surgeries, yes.
Yeah. Thank you.
We know about it. Thank you.
Thank you for our presentation. If you go back to the systematic search slide for your second project. Yes, the date 15th of December, and you already have numbers.
Yeah, it's the numbers of the preliminary research.
Like you already put the search key and search, and you got these numbers?
Yeah. I mean.
And you're going to do another search on 15th of December?
So it's just we just tried this search key, and we've seen what kind of numbers we can get. So that's what our preliminary research was.
Yeah, so the numbers, I think they're going to be changed, like for sure.
It's going to be bigger, yes.
Yeah, okay. Thank you.
Well, as you presented, this one seems to be very simple. I mean, well, instead of kind of taking the meniscus away, it should be regenerated. You still said that 94% actually, I mean, use this kind of removal of that. And then 6% who tries to regenerate that. The surgical technology kind of, I wouldn't say the same, but the difficulty is the same, or
No,
I assume
no.
that the second one is much more difficult.
It's exactly like that. Meniscectomy is much more easier, shorter, and obviously doesn't have a complication rate like failure rate.
So
with
it doesn't have. Well, in your hands maybe not, but so are you really sure that there are no complications, especially in a procedure which is very complicated and maybe
the other way around. So with meniscus repair, there is a failure rate associated with it.
Okay.
Obviously,
anyway,
not healing of the meniscus.
Anyway, as we look here, that today we live in the area of regenerative medicine. So this is the way to go to, I think. So this is very good, very promising.
This is what we believe in too.